Everybody, and welcome to Columbia Commons IPE Day. My name is Phyllis Simon, and I am a faculty member from the Occupational Therapy Program and part of Columbia Commons, and I am so excited to have this group here with us. So again, for those of you coming in, there are seats up here. There are cases, paper cases, and just the seating is color-coded by your profession, just to take a look. So I'm just going to put the QR code. Everybody's coming down. So as you know, there's a number of sessions throughout the day. I'm going to put up a QR code for attendance, okay? So if everybody could. So this is for the session today to make sure that everybody registers. And then at the end of the day, you'll be sent a evaluation for this as well. So today's session is entitled The Burning Heart, How a Burn Team Treats a Patient from Acute Injury to Rehabilitation and Reintegration. And I am so honored to have met and work with this esteemed team from Cornell. And is everybody good on here? Or leave it up a couple of minutes? I'll leave it up for a few minutes. And I have to say, I began my career at Cornell and had, over 30 years ago, and had the privilege of spending a year on this service. And it really is an experience that I would hope that all of you can encounter, a team experience and interprofessional experience, working on an interprofessional team like they have here together, okay? I'll put this back up again afterwards, but I just want to get started. So here we go. So as I said, this colleague, I'm going to turn it over. This is the interprofessional team, and you could see that it really is quite expansive and covers a wide range of disciplines that are required to treat and work on this team. So I'm going to turn it over to the team to actually allow them to introduce themselves. So you can come up. Yeah.
Good morning, everyone. Thank you for joining us for this exciting morning. My name is Dr. Philip Cheng. I'm one of the attending burn surgeons at New York Presbyterian Weill Cornell Medical Center. And
my name is Sylvia Dow. I'm the patient care director of 8 West Burn Center at Cornell. I've been at the Burn Center for 11 years as staff nurse and then nurse management.
Good morning, everyone. My name is Ekta Vora, and I am the burn outreach nurse at the Burn Center.
Good morning. I'm Patty Kallenberg. I'm the social worker on the burn unit. I've been there for about 3 years and social worker for 12.
Good morning, everybody. My name is Megan McCarthy. I am the senior occupational therapist at New York Presbyterian. I am the burn senior of the Burn Center. I also have been there for about 9.5, going on 10 years. Aside from that, I also work in global health with one of our chief attendings in Tanzania, and we go once a year to try to establish burn care in the country.
Good morning, everyone. My name is Malvina Sher. I'm a senior physical therapist at the Burn Center, and I've been working there over 20 years.
Hi, everybody. I'm Robin Silver. I'm one of the occupational therapy supervisors. I've worked at Cornell for 31 years. I've worked on the Burn Center for pretty much almost all of that time, as well as the acute care hospital in general. And I can just say, like Phyllis, it's a great place to work, and you really do work with the interdisciplinary team. And I just also want to forewarn you that some of the pictures are a little graphic. So if it bothers anyone, just close your eyes.
Good morning. I'm Dr. Corinne Catarizzoli. I'm a clinical psychologist at Weill Cornell, specializing in pediatrics, and have been working with the wonderful 8 West team.
Okay. Thank you. So here, everybody has the handout. The learning objectives are listed here, but hopefully through this experience, you'll gain an understanding of the role of the interprofessional team, burn care team in managing acute, as well as the long-term needs of burn survivorship. You'll learn about the factors and considerations that influence the provision of care and understand the difficult clinical, physical, psychological, emotional, and ethical challenges and decisions that are faced by this team. So with no further ado, I will turn it over to Dr. Chang.
All right. So thank you, everyone. I know many of you all may not get the chance to directly rotate with a burn team, but through this morning's activities, we want to give you a sense of how important it is to have a cohesive team-based approach when we're taking care of our burn patients. That's doubly true, especially when it comes to our pediatric burn population. Among all the various types of care that our health care system provides, burn team care has been one of the most established paradigms of interprofessional team care across the decades. This involves truly participation and the expertise of multiple, as you can see, gathered here today. So it takes decades of experience in all our respective fields to really deliver the optimal care for our burn patients. In order for a team like this to function well, you obviously need multiple aspects of character and quality to make a team function, such as trust in each other's expertise and intentions, respect for each other's skills and experience that we've built over the years, as well as respect for the patient, and especially for pediatric, respect for the parents and extended family, and problem solving. You learn a lot in your textbooks, you learn in your classrooms, and then once you start your job, it's a totally different ball game. But you do draw upon the knowledge that you've learned through your degree programs, and then use that knowledge to problem solve in the real world. Because oftentimes, it's not just about the ideal solution, but what the best possible solution is, depending on the resources available to the family, as well as to the team and the institution that you work at. Needless to say, to make all the pieces come together, like having a symphony come together, it's all about communication. It takes both communication behind the scenes, communication with the patients, and communication among team members. One of the keys to our functioning as a team are regular meetings that we do twice a week. We call these multidisciplinary rounds, and we gather twice a week where all the team members from all the specialties will gather, and we'll talk about each patient in detail for all aspects of their care, including the medical, the social, the therapy aspects, the nutritional, psychological, psychiatric, as well as spiritual sometimes. And by having all the team members contribute at these multidisciplinaries, we can get a holistic approach to the care of our patients. So in order to kind of help set the context for the discussion we'll have shortly, I've got to give you all a quick crash course about burn injuries. So this is the part where, unfortunately, we will, as you were warned, some of the pictures may be a bit upsetting, so I apologize in advance. So burn injuries, this classification system of first, second, third degree goes all the way back to originally the 1500s. There was a German surgeon who described this, and that classification system still works to this day, amazingly. So we talk about first, second, or third degree burns. In more clinical, in more modern textbooks, you may see the terminology of superficial, partial thickness, and full thickness. These terms are interchangeable, but you'll find that most patients are more familiar with the first, second, third degree terminology. So it's more useful to communicate with patients that way. And then perhaps with your clinical partners, you will converse in superficial, partial thickness, and full thickness. So a first degree burn is analogous to a sunburn, where you've got skin injury through the top layers of the skin, the epidermis, but it doesn't extend further. One key of the first degree burn is that there's no blistering. The skin stays intact, but is quite reddened or stained by the burn injury. These first degree burns are painful, but we usually expect these burn wounds to heal or resolve within 5 to 7 days, and usually these burn wounds leave no long-term scars. The secondary burns are where the diagnostic challenge comes into play because secondary burns go through varying depths of both of the dermis. So the secondary burn goes all the way through the epidermis here and then extends to various layers of the dermis. And this is where we talk about superficial secondary burns, which may affect just the top half of the dermis, and versus the deep secondary burns, which will extend all the way down into the deeper layers of the dermis. The superficial secondary burn wounds, the classic sign is blistering. When you see the epidermis blister off and you can see this pink skin, that is the dermis that you are seeing. Thus, that way you can tell that burn wound has extended down to the dermis. Superficial burns, we usually expect to have reepithelialization anywhere from 1 to 3 weeks after injury. If that reepithelialization does occur in that time frame, usually there's no long-term raised scarring, but there are pigmentation changes that occur, and it can take anywhere from 6 months to a year for that pigmentation to come back. The deeper secondary burns, as illustrated in this photograph here, oftentimes will extend down to the very deepest layers of the dermis. And these are the burns that sometimes do require surgical treatment, in other words, skin grafting, in order to close these wounds. Deep secondary burn wounds start becoming at risk of forming raised scars with potential consequences for scar contracture formation, as well as itching, neurological pain, social disfigurement. So these are the wounds that start having the impact that require the care of the multidisciplinary team. And then finally, third degree or full thickness burn injuries go through all the layers of the skin. The skin basically has been destroyed by the agent that caused burn, whether it be heat, chemical, electricity, cold injury, or other. And we sometimes use the terminology of fourth degree burns to describe those burns that extend all the way into the deepest tissues underneath, the muscle, the bone. On occasion, we have seen burns extend down to even the abdominal viscera. And these burns are a significant challenge to ultimately close. So besides describing the depth of burn injury, it's important to also describe the size of burn injury. Now, one could break out their rulers and measure in centimeters the size of burn injury, but it's not so helpful because knowing that a 10 by 10 centimeter burn injury on a baby versus a 10 by 10 centimeter burn injury on a big 350-pound adult, that size doesn't tell you much. It's more important to describe it in terms of percent total body surface area, or TBSA for short. By using the percent TBSA units, that rapidly gives our team a sense of if this is a small burn injury that will require outpatient care versus a medium-sized burn injury that does require inpatient hospitalization versus a large burn injury that will require intensive care unit care and potentially has a risk of even death for these patients. So there are a couple ways that we measure percent TBSA burns. In your textbooks, some of y'all may have read about the rule of nines. This is a quick rule of thumb that assumes a certain size patient, typically 70-kilogram adult personality, and that these areas of the body can be described as multiples of 9. For example, the entire arm is 9%. The entire front of the chest is 18%. The entire leg from thigh down to foot is 18%. The entire head, front and back is 9%. And it leaves 1% for the perineal area. The rule of nines is great if you have a patient with a large burn injury. It is not as helpful, however, for the vast majority of the burn patients we see, for example, in the emergency department, who tend to have much smaller burn injuries, typically from a scald injury or spilled cup of coffee or ramen noodles. So for those smaller burns, it's easier to use the patient's hand size, or what we call the Palmer rule. So the patient's hand is roughly at 1 to 2% TBSA, and this allows us to quickly assess the size of the burn injury by using the patient's hand. Very important not to use the clinician's hand. So, for example, if you used your own hand size on a kid, you might grossly underestimate the size of the burn injury on that child. The gold standard in our field at this time for assessing burn size is a chart called the Lund-Browder chart, which was based in research in the 1920s and formalized in the 1940s, but it's still used to this day. And it basically gives you a table based on the age of the patient you're taking care of, because children have a different size proportion than adults. For example, if you notice in this child, the head of the child is 18%, or twice the total body surface area compared to which is just 9%. The Lund-Browder chart will fill in the diagram and then break it down based on different body parts to get us a more accurate total body surface area estimate of the size. And one important thing for clinical purposes, We only count the areas of second and third degree burn or partial or full thickness when we're counting these burn sites, because those are the depths at which there's clinically significant effects, both on terms of wound healing and wound care, as well as overall systemic effects on the body. A third piece of information that's important when assessing burn injury is the mechanism. Different mechanisms will lead to different expected courses of recovery or injury progression, as well as other potential additional injuries that can be expected to accompany the mechanism. So, by far, the most common cause of injury in the pediatric population are scald injuries. Typically, a very typical story you'll see almost every day in the emergency department is a child who actually pulled down a cup of tea or coffee that their parents had just prepared, or perhaps an older child, an adolescent, was heating up a cup of ramen noodles in the microwave and actually tipped over the ramen noodles when they reached up for that microwave. There's also even cultural sometimes patterns in burn injury. For example, the Orthodox Jewish population, for example, on Shabbos, obviously they're limited in terms of some of the activities they can do. So they will often prepare hot water heaters and help prepare meals. And sometimes these hot water bowls can tip over, causing significant burn injuries to their family members. Flame injuries at this time of year can often be caused by apartment or house fires. Frostbite, thickness, we're passing finally out of the cold season, but clearly, as a city that spends a lot of time in winter, we do see a fair number of patients who sustain various cold injuries, especially in our more challenging populations, such as the undomiciled population or immigrant populations that may have a hard time finding housing easily. Contact burns are fairly frequent in our city compared to other cities, especially because we have exposed radiators in most of our apartment and housing buildings in the city, as well as cooking accidents that can happen in terms of accidental contact with ovens, stoves, and hot pots. Electrical burns in our city do occur both in an industrial context as well as third rail accidents with trains and subways. Chemical burns, fortunately, are not as common in our cities and other parts of the country where we don't have as many chemical factories here in the city, but nevertheless, we do see chemical injuries with some regularity because of the plethora of cleaning chemicals that are available. And then inhalation injury. Some of y'all may have recalled last year there was a significant apartment tower fire in the Bronx, the Evergreen Towers fire, where a number of patients unfortunately died in that fire. And it wasn't due to flame injuries, it was because of the smoke inhalation that happened. So there are multiple types of burns, as you can see here. And identifying the mechanism based on history is an important part of assessing the burn patient. So when it comes to those deep second and third degree burns, wound closure does require, on occasion, surgical intervention. This is where the surgical members of the team come in terms of the mainstay of our care is still the split thickness skin graft, where we take skin from the patient's own body at a thin depth, like anywhere from 8 to 12 1/1000ths of an inch, and then put that skin graft on the burn wound after the burn wound has been cleaned. Sometimes if the burn wound is small or if the patient is not a great, what we call an operative candidate, maybe because they have a lot of medical comorbidities, sometimes for smaller wounds, we will allow the patient to gradually heal in the wounds by themselves. That's where we get the delayed wound care strategy or secondary intention. Oftentimes when there are burn wounds that have extended down to deeper structures such as exposed tendon or muscle, especially on the hand or the feet and ankles, we will use advanced technology such as dermal templates or artificial skin substitutes. In this case, you can see a picture of one of the skin substitutes that we used and that we'll talk about later in this for our case presentation, Integra, which was a skin substitute originally developed in the late 1980s and we still use to this day. Since then, there have been a number of advances made in other skin substitutes as well, but this skin substitute allows us to place this over an area that wouldn't usually sustain the skin graft. Then over the course of a few weeks, the body is able to grow new blood vessels and new connections into that area. And finally, we're able to place a thin skin graft over that skin substitute. For very challenging areas of the body that this approach can't work. We sometimes will require the advanced skills of our plastic surgery colleagues to do what are called flaps, which means moving an adjacent area or perhaps a distant area of skin, sometimes underlying fascia and muscle, to cover the exposed area. This technique is often used, for example, for deep burns to the scalp or large open wounds that have exposed bone on the legs or the arms or the hand.
All right, so now for the fun part, after we just got through a course of Burn Patho 101, we're going to go through a case study now, and we're going to break down the case study into two parts. So the case study focuses on a 7-month-old male that sustained a 5% contact burn to the left lower extremity, affecting the thigh, knee, leg, and ankle. So the two phases is the acute phase, which kind of focuses on the acute hospitalization of his initial injury. And then the second phase goes into his rehabilitation phase, or we also call it his burn survivorship phase. So let's get to it. In February of 2016, we get this child, 7-month-old male, admitted to the ED after sustaining this injury 2.5 hours after his injury. The story goes, per report, dad left baby on bed, surrounded him by pillows, thought he was okay. This is common around this age as well because babies start to roll, and lo and behold, he did roll off the bed and pinned himself in between the bed and the radiator. And similar to what Dr. Chang was saying, this is very common in New York City. How small are our apartments? I guarantee a good percentage of your beds are against the radiator. So safety things to take into consideration. ECTA can highlight some preventative measures that we also do as a burn team to prevent this, but it does happen quite often. Some other background for this child, his only past medical history is bronchiolitis, no other allergies or no home medications. Also some context, we found he does live with both his parents. They're unmarried, 18 years of age, and unemployed. He also lives with other extended family members at home. So when you see these patients either in the fields, in the ED, on your units, every time you assess this patient, you go through your primary and secondary survey. So I kind of want to highlight this for this group. When you are seeing these patients, this is the first thing you do every time you see the patient. Airway, breathing, circulation, delirium, or their neurostatus, and their exposure. And then once you confirm all of that's stable, then you move on to your secondary survey. What are their signs and symptoms that they're exhibiting? Allergies, medications, past medical history, when was their last intake and output, and then you get the history of what led up to this event. So you think of A, B, C, D, and E for your primary, and the acronym SAMPLE for your secondary. So luckily for us, this patient wasn't too critically ill. He was fairly stable, so our primary and secondary survey went pretty smoothly. His vital signs were stable, temperature 37, heart rate 143, respiratory rate 24, setting 99% on room air. His blood pressure was 88/56, and he weighed 7.6 kilograms. Again, everything was within normal limits for his primary survey. I want to highlight circulation. Neurovascular checks are super important for burns. Not only for circumferential burns, thankfully this patient didn't have that, but if the burns are deep enough, it could affect vasculature and affect circulation to that limb, so it's very important that that gets assessed right away. So C, circulation, primary assessment. In addition, E for exposure, the wound's exposed. So if you're seeing this patient in the field, in the ED, or on the unit, and the wound's exposed, you want to make sure you cover that, at least temporarily, until you could get a more stable dressing on. Usually it's a non-adherent dressing. If you don't have access to that, then a wet gauze, saline-soaked gauze, is appropriate. But with that said, patients get colds, they're missing their skin, it's hard to thermoregulate, so you want to make sure that you keep them warm at the same time with a warm blanket. secondary survey. So he came in, as we said, 5% contact burn to left thigh, knee, leg, ankle, exhibiting also signs of pain. And again, this just organizes everything that we went over, past medical history of bronchiolitis and the events leading up to the incident. All right, so this slide just goes over his entire hospitalization in a nutshell. When you care for burn patients particularly, you have, or all patients in general, you have two overarching goals that you need to keep in mind. One, do no further harm, and two, get them back to their baseline as close as you can. So when you consider all of these aspects, essentially this is everything you have to do. You manage the medications, their pain and anxiety, make sure they're hydrated with great nutrition, make sure their labs are normal, which are good indicators of hydration and nutrition, and of course, the wound care aspects. This takes a huge load of his hospitalization. So if we're not doing wound care twice a day by medicating the patients, cleaning the wounds, dressing the wounds, we're continually assessing the patient and their need for surgery at the same time, or if they are able to heal and re-epithelialize on their own. So after 12 days of good wound care, the decision was made to do a skin graft surgery on day 12 of his hospitalization. Skin graft care, typically, in a nutshell, the dressing stays on place for 5 days. You take it down after 5 days. If it looks good, if it didn't deteriorate, then, and hopefully it doesn't need any more surgery, which is what this patient experienced. I want to highlight wound care, especially for the nurses in the room. Raise your hand if you're a nurse. Like 10 nurses, okay. But goals of wound care. 1, you prevent infection, and 2, you want to provide a clean, moist, healing environment to either promote re-epithelialization or optimize the wound bed for a skin graft to successfully take. Again, wound care, it provides temporary coverage. It helps minimize evaporative water loss, which is key to minimize dehydration and heat loss. And it helps protect exposed tissue and tendons from further damage. So wound care is super, super important for nursing.
Can everybody hear me? All right, can everybody hear me now?
Yes.
Okay, so real quick, just before we get into the specifics about this case, I just want to go over briefly what burn rehabilitation is. So the main part of the way our body heals is from the outer borders in. So the main process of the skin is it wants to get tight, it wants to contract, it wants to heal as fast as possible. So what that can cause is our joints to get tight, and individuals are constantly playing tug of war with their skin, not only for the acute phases, but months after injury up to a year. So it's very normal for us as therapists to say one day, hey, your motion looks great, and then the next morning they wake up stiff as a board. So we're constantly trying to educate individuals on the recovery process in the acute phase, but also prep them for months to years down end. So how do we maintain the elasticity of the skin? So we utilize functional tasks of what the individuals have to be able to do on a daily basis. We use repetitive exercises to stretch that skin both actively and passively. We utilize positioning and splinting. This is a very important part of burn rehabilitation. We actually do go into the operating rooms with our surgeons about toward the end of the case, about 15 minutes before it's completed, and we will actually splint individuals under anesthesia before they wake up to optimize their position as their skin starts to heal. With children, their main occupation is play and development. So with a child, you can't go in to the room and say, you know, come on, let's exercise today. They also don't understand why they're in pain and why we're pushing them to move. So it's really important to use occupational-based play development. Along that, we use play to achieve their motion, help them along their developmental process depending on what age group they're at. The difference between OT and PT amongst our burn rehab team is a true team collaboration process. We go through a aggressive mentorship program, training program to really treat the whole person. So what's different in this area of specialty is myself as an OT, I can treat a lower extremity ankle. My PT counterpart can treat a hand. Where that comes in is we're constantly talking to each other on a daily basis, where if we see anything that we want them to take a look at, get involved, the way we do separate is OT will handle cognition with the inhalation patients. It is normal when you inhale a lot of smoke, you can get something called delirium. And then also to any like complex hand nerve injuries where ligaments, tendons are involved, we will get OT involved in that case. And then PT-wise, any tendon involvement in the lower extremity, any assisted device training with stairs, that's kind of where we divide the line. In a pediatric case, if patients are not meeting their developmental milestones, that's where both of us will get involved. And then the last time that we both will see patients is when we have a bigger burn. Because when you have over a 30% burn, a lot of work has to be done because the skin is pulling at all angles. So we will kind of divide and conquer in those cases. So in this case, Melvina had the pleasure of treating this individual.
Hi, everybody. So on initial eval, this child was 7 months old. So what you're looking at the 7 months old, yes, you assess range of motion, you assess his age-appropriate functional activities. Can he really, role transition? Can he participate and play willingly? How he interacts with others, not only the family members, at which point we had both parents, coming and visiting and playing with him. So you're also looking at interaction with the therapists, doctors, nursing staff, anybody pretty much who walks in the room. You want to see if child, reaches, smiling. You're looking at the range of motion. So the 7 months old, you can't really tell patient to, let's move your ankle, let's move your leg, let's move your arm. You, number one, observing the range of motion through transition and functional actions, but also you measuring range of motion, which is at this point would be passive range of motion. So on initial eval, this child had within normal passive range of motion. There were no limitations, even though the burn crosses his knee and very close to the ankle. He was able to cross midline when reaching for toys. He was able to sit unsupported. Standing was, he's 7 months old, he has supported standing, but he demonstrated ability to full weight bear through the foot, and there was no preference of using or standing on one leg versus another one. Like I mentioned before, he was able to participate in playing. When it was time for the surgery, we came at the end of the surgery and I applied cast. Because it crosses two joints, ankle and foot, it was a long leg cast. The reason we cast children more than adults is because for children it's difficult to explain that they have to maintain splint in order to maximize taking of the graft. So the preference to put a cast so they don't take it off, even though they really try hard to do that. In his case, we positioned his ankle in neutral, which is like dorsiflexion, and because the graft was very close to the knee or crossing the knee a little bit, we had to do it straight. Normally, I would place knee at least a 90 degree, and again, to prevent sliding of the cast. And discharge recommendation for this child, because she didn't demonstrate any limitations or any delay, was for the outpatient physical therapy to make sure he continued reaching his milestones. He continues from sitting to standing to walking eventually, and that's what we expected with the outpatient therapy.
Hi again, I'm the social worker. So just to start, on our unit, we have the privilege of working with both adults and kids, so I'm going to talk mostly about kids, but the one thing I will say is, one thing that I've learned on the burn service is that the burn is often just a symptom of something else going on, often a social situation or a social barrier to care, and so I find that my role is very, very fruitful and busy, and I will always have a job. So just wanted to put that out there. But my job really in the acute phase and the hospitalization phase is to kind of understand the patient and family of every aspect of their life, not just their medical piece or kind of what brought them in, but kind of understand who they are as a whole and how that might, the things they bring in from their every aspect of their life impact maybe the care that they're going to get or continue to get. So the first thing we do as social work going in is we actually assess every single burn patient, no matter what. It is an immediate assessment for social work. So we kind of go in there and do an in-depth assessment. So with the kids, the one thing we really do focus on, I don't focus on as much with adults, is kind of how did this injury occur? And really kind of sit down with the parent or the kid if they're at an age appropriate where they can talk to me about it and ask them how it occurred. In this case, we would kind of get a sense of what the house looks like. Was the radiator did not have a cover? As Dr. Chang said, a lot of our housing, NYCHA, which is New York City housing, they don't have covers for families on radiators. A lot of our families will come in and say, I've asked for 5 or 6 times. I've wrote letters, I've had doctors write letters, and they just haven't covered radiators. So this is a common occurrence we have. Families do like pillow barriers and towel barriers and all these things to kind of help mediate the situation, but often this ends up happening. But how did it occur is the nature and the extent of the injury. Is it consistent with the history provided? So often I'll go to my doctors, this is a scald burn, and they'll be like, yep, we can tell by the pattern of the burn that there's splashing, and it does look consistent with the story provided. And we also just want to make sure the story is consistent, and I always kind of tell the parents, I know it's annoying, we have to ask the story again and again, but we just want to make sure it's a consistent story, because sometimes it isn't, or sometimes there's a miscommunication that we want to kind of understand. We really kind of get a good sense of the family system. I would say with pediatric assessments, they're a little bit more personal and uncomfortable, so just talking about who the parents are they together, what's the nature of their, and that's always can be a little dicey when you ask about their relationship status. The custody, who has custody of the child? Are they working? What are their social supports outside of the parents? I mean, I think a lot of the times we see our patients don't have a lot of support, and the parents have to work or have other children, and often their child's left in the care of us, which I know a lot of people have lots of feelings about, but our families have a lot of things going on outside of just this, medical situation. Their living situation, their insurance, kind of all that kind of stuff we ask. We ask about if they're in school, if they're in daycare, do they have any services? If they're not in school, if they're not in daycare and the parents are employed, who's watching them? And things like that. We ask them about their pediatrician. We try to just make sure they attend their appointments. Are they up to date with their shots? And things like that. And then the one thing we always ask is, which I always find kind of uncomfortable, but I always have to ask it, is has there been a history of ACS or Children's Services involvement? And a lot of the times our burn kids will be transferred from other hospitals that don't have burn centers, and ACS has been initiated, and that's something we help navigate with them because it is something that then impacts their care and even outside the hospital. Throughout the hospital, after we do that assessment, we consistently provide support and counseling. We have various services we use that are burn specific. We have a SOAR program, which is a peer-to-peer support program. So often with pediatric patients, I find a lot of my job is around the parents and supporting them. There's so much guilt, there's so much woulda, coulda, shoulda, replaying everything. There's arguments between the parents. One parent was home with the child, the other wasn't. How can you let this happen? So a lot of just support. So we have a parent supporter that we pair with our parents some time and kind of just help as an extra support of dealing with what they're going through. The Phoenix Society is a great organization. If anyone is interested, just to look it up after. It's a burn survivor organization. It has a lot of great resources and support for our patients. We have a child life team who, they're not here, but they're amazing. They are there with our patients during wound care. They are there during surgeries. They do a bunch of different things to kind of help them. We do family meetings, which is something I really am so proud to be a part of on this team, is when we have a big burn or kind of a tough situation. And I think with this patient on his last hospitalization, we did have a family meeting, and we all get together and we kind of each have an opportunity to talk about our specialty and help the family and patient and then child psych, but she's here, she's amazing, and she'll explain more later. Discharge planning, that's our bread and butter. So we work with our team, our interprofessional team, to kind of determine needs. Some of the services we do, for PEDS patients, we do send patients to rehab, we set up services, we identify family members who can do wound care, transportation. With our adult population, we do nursing home placement, hospice, everything you really can think of, shelter placement, psych placement, just going through my list right now, alcohol placement. So we do kind of everything, but mostly with kids, we often send them home, luckily, and work with ACS if that's involved. For this specific case, the recommendation after the acute phase for this hospitalization was home with a referral for outpatient PT. So the family was instructed, and often they're taught once or maybe more than once by our nursing staff until they're comfortable of the wound care. So in this situation, it was lotion, and were measured for compression garments, and they were told to continue to be active. PT was going to begin the week after discharge for exercise, splinting, casting, and to maintain a range of motion. And then, as always, they follow up 1 week after burn clinic, 1 week after hospitalization in burn clinic. And we also have an outpatient social worker in the burn clinic who continues to follow these patients.
Okay, so let's do a breakout discussion. You can speak amongst yourselves and go through these questions. We'll spend let's do 5 minutes. I think that should be okay. So first question is, from your professional area of practice, what are your priorities for this patient's care? The second one is, what psychosocial considerations do you think may have impact in the patient's care? And what are some issues or personal concerns that the interprofessional burn team may have encountered in managing the patient's care? So let's take 5 minutes, speak amongst yourselves, don't be shy, and let's do it.
Oh, great. Okay, if everybody could start wrapping it up. I know it's a really rich case, but there's another really interesting section to this as well.
Okay. Thank you, Phyllis.
Yeah.
All right, everyone. So for the first question, if anybody wants to come up, or you can speak from your seat if you're loud enough, like me. So let's just say what discipline you're from, and let's share. Any takers? Come on down. Yeah, we can choose volunteers. Yes.
Thank you. So the comment was from occupational therapy. So obviously the play, to have the child engage in the play activities and a lot of the physical rehab, the splinting, and those types of activities to make sure the child is engaged in the types of activities that they would normally be doing, even within the hospital environment. So feeding, playing, engaging with other children. That's a good part. Anybody else? We have a mic coming. Is that
I'm trying to, can you all hear me? Okay,
Yeah.
great. Hi. From the nursing perspective, I think number one would definitely be pain management. That is what we're expecting. And definitely we will see challenging assessing a 7-month-old pain levels. And then secondly, I think a risk for infections, and definitely check the vital signs to see and to detect any early signs of infections. And then the other one would be wound care, but if it was already not taken care by the debridement specialty team. And then another really important nursing role is because we spend so much time with the patient in comparison to other interdisciplinary teams. So definitely facilitate communications between different teams. For example, if the OT or PT comes in, we just update them of what we observed during our care to make sure there's a smooth collaborations between all the team.
That's great. That's great. Thank you. Go ahead.
Get an A.
Any other questions, thoughts? Did somebody?
So from an occupational therapist perspective, I think we should also consider edema management and maintaining like anti-deformity positions, because it's really easy for the skin to like contract. So it's really important to help maintain a position which is like limiting contractures and deformities.
Yeah, good point. Any other? People can comment on the other questions as well.
Yeah.
Hi, I'm also from occupational therapy, but I was thinking about the psychosocial considerations and the support that potentially the parents who are not only 18 and maybe pursuing education, but also now have a kid who also has a burn injury to take care of. That might be something to take into consideration, but also this patient, as they grow up, like they are gonna need support systems, and I just think about the potential for them to go to things like burn camp or just to be part of groups of survivors that can help them manage. I mean, the kid's gonna have scars, the kid's gonna potentially have things that they need to take care of throughout their life, and so just being able to be part of a group that can aid them in that might be helpful.
Yeah, that was a great point. I don't know if somebody from the... Yeah.
Those are all great points. We actually just sent an email yesterday requesting that this child pursue to go to burn camp. So those are all support systems. I don't know if anybody knows that for burn camp is the ECTA institute for that.
And I also just wanted to share that sometimes, because as you know with this case, this is very common that we have young parents, we have parents that don't have a lot of education, they don't have a lot of skills to take care of their children and or the supports. So sometimes, in a way, it can be a blessing in disguise that this happens to some of these children, because then we put them under our umbrella and we follow them for a very, very long time. Almost their whole lives we see the patients because of how the burn course evolves. And with a child, because a child is growing, the burn gets tighter and tighter, and they often need subsequent surgeries to loosen up their body. So sometimes it really helps these children in particular, but the adults as well, but just to have the support that they need and an educated eye to help them have the proper resources to live a very successful life.
And just a little bit more about burn camp. It's really a wonderful opportunity for children who have suffered burn injuries or burn survivors to connect with one another. And there's wonderful workshops, and it's just a real way to build community amongst these patients that have gone through this really traumatic thing. And the truth is, it really doesn't matter the size of the burn. That does not always equate to the trauma that the patient experiences. And it's a great way also for burn professionals to participate and be a part of this awesome week.
Yeah, I firsthand have been a counselor at burn camp, and I love that you mentioned it. In addition to like being with your peers, with similar burn injuries. You see these kids blossom up from day one. They're in this shell, and then by day 7, they're exchanging numbers, best friends, playing, and they go through a lot of challenges, and it's really nice to put them in an environment where they could feel normal and reintegrate back.
Just a question. Who pays for burn camp?
That's a good question, actually. So it's free, right?
It's free. So Arthur C. Luke Children's Burn Camp is held once a year. It's a week long. Members volunteer to serve as counselors there, and a lot of the kids come back as volunteer counselors to give back to the experiences that they had. But there's foundations that help support. There's a lot of burn center foundations. Connecticut has one, Boston, DC, the New York Firefighters Burn Center Foundation helps support this. So there's a lot of good fundraising efforts.
Anyone on the third question? What are some issues or personal concerns that the interprofessional burn team may encounter?
We just have the mic coming around. Can you guys hear everybody? Yeah?
Okay, so from a nutrition standpoint, I was wondering if we could pay attention to some malnutrition signs. So possibly suggesting that parents could recidivize since they do not have, they're not married, or they don't necessarily take care of the child very carefully, it seems. So there's a possibility for such episodes to repeat. And if you can see malnutrition signs or other burning signs as warning signs to similar events reproducing themselves. So that would be one of the concerns. And just to add to the first question that we were supposed to respond to earlier, we might want to make sure they get the appropriate macronutrient and micronutrient intake to strengthen the immune system and wound healing capacities of the child. Yeah.
Those are all great points. We could probably spend the entire time talking about nutrition and its impact on burns alone. Thank you. Wow.
Yeah. Any?
On behalf of our burn nutritionist, Emily, who would love the points you raised, especially in this age group, there's challenges. A number of the mothers really want to continue breastfeeding their children when they're burned, and we do our best to try to coordinate ongoing breastfeeding as well as nutritional supplementation in this group. For some of the children with large burns, they will require enteral nutritional support, so we'll have to place feeding tubes through their nose, which can obviously be a source of discomfort, but we are often successful in continuing breastfeeding in addition to the enteral nutrition support that's needed. You raised an excellent point about the nutritional assessments. It's not uncommon for some of these patients to come in borderline marginal, nourished, or even sometimes malnourished even before the injury starts. And burn injuries greatly increase the metabolic rate. They can lead to a catabolic state where the burn patients are using up their lean body mass. It was not uncommon back in the 1950s and 60s, before we were aware of the importance of nutrition, for burn patients to basically become starved in hospitals and die of malnutrition. Fortunately, that does not happen in the modern era, but it is something that is of vital monitoring when we're taking care of these patients. So I thank you for raising those excellent points.
Great.
I also want to share, it's something else we look at from a developmental standpoint, because sometimes maybe they're breastfeeding like longer than they really should from a developmental standpoint, so they're not eating solid foods when they should start, and we just really look developmentally. Are they doing what they're supposed to be doing at a certain time frame? Because sometimes some of these accidents could happen because they might not be meeting their developmental milestones.
Okay. Okay, we're going to move on to the next part. These are all really good questions. Sorry about the mics. We're trying to figure out. You have a lot of
brought up. So we basically housed him for about 2 weeks got weight back up, got his range to be normal again, and then ultimately we recommended that this individual go to acute rehab because it was obvious that the parents and the outpatient services were not being followed up on. So this individual went to acute rehab around 8 months old and then transitioned to a day program at the facility 5 days a week.
So one of the rehabs, this patient was transferred to actually great because they keep their children for a long period of time where kids can go to the acute rehab and then transition into the outpatient program, including school, any kind of educational needs that can be provided to a child there. So at this point, child still had discharged like full range of motion, and we provided him with the garment, compression garment, to make sure the scarring was not affecting his function. At the rehab, they made him knee, ankle, foot orthotic to make sure that, again, he is weight bearing through the lower extremity when he is walking. Patient eventually become, again, non-compliant on one additional discharges home, and he developed thick hypertrophic scar crossing knee and ankle joint, and at this point it affected severely his ankle. Contracture was pretty severe enough to affect his development, and when he came to one of follow-up visits to clinic, decision was made to have another surgery sooner rather than later. So in November 2016, he had early scar excision and release of the contracture. Autograft was followed in the lower extremity, and at that point, on the discharge again to the acute rehab, a child was serially casted to make sure the ankle and the knee stayed in had normal range of motion. And another follow-up, he was discharged at the acute rehab with intention to transfer to the outpatient treatment program and day school program. At follow-up visit by 2017, now child is 1 year and 11 months. Still not walking spontaneously and will not place his foot on the ground fully in standing. By 2018, still again not walking up to the age-appropriate expectations. He is doing the toe walking, and at this point, child fell off the grid for us, and there was no follow-up visit until 2021.
Dr. Cheng is back.
All right, so we jump ahead to 2021. We're through the first couple waves of COVID at this point, so we're all masking up in the clinics. And so I get to see this young child in clinic. He's gotten much taller since the last time our team saw him. He's and unfortunately, the first thing that's immediately noticeable as he walks in the clinic, he is not walking very comfortably. He definitely has difficulty standing and making his legs straight, especially on the left leg. Dad lets us know that this child really can't wear shoes. He's been, I think, getting by on sandals, open-toe sandals, but this obviously is a challenge living in New York City. Can't really wear sandals too comfortably in wintertime. And it becomes very clear that there's not a non-surgical way to really manage this situation given how tight the scars are. Of note, our therapy team also notes that in addition to issues at the skin level with the scar, the Achilles tendon is very tight. Of note, the child is also, fortunately, despite these challenges of ambulating, is able to attend school and is going on with outpatient therapy. Let's see. So our plan then becomes to admit the child, plan to do a 2-stage surgical procedure to release the scar, and then hopefully with serial casting, we're talking that we can make some progress with the Achilles tendon as well. And eventually, after the first stage surgery, where we remove the scar, cover the area with one of the skin substitutes, in this case Integra. Then it takes about a couple of weeks for that Integra to mature. Then we place the skin graft over that area. And we utilize the time while inpatient to work on the child's therapy, also work on the child's nutritional status, as well as other aspects of his development. Let's see. And then, how do you want to talk a little bit about the social obstacles?
So yeah, so actually this is when I got to meet this patient when he was a little older. So at this time, the situation changed a little bit differently. He was living with just his father in an apartment. His father was fully employed, and it's not on here, but he also was caring for his, I believe, 16-year-old brother. So he had a lot on his plate. ACS had been involved, obviously when our team called it in, but throughout kind of this whole time, as the mother was using drugs and as a result lost custody and was no longer involved in the child's life. What we did kind of to try to help at that time is we, with the child being in the hospital for several weeks, it was really hard for the dad to get here via public transportation. So we did a couple things. We worked with the patient's insurance to get Medicaid transportation. We also, it's not on here, worked with the Burn Foundation and got the father coverage for an unlimited Metro card. So we kind of tried to help. Obviously, he's not our patient, but they're all our patient, the whole family, to try to make it easier because it was really hard for him to visit all the way from the Bronx to our hospital on the Upper East Side.
Yeah. Okay. Yeah.
All right. So a little bit of the gory surgical details. So, so we started off the plan to do the Integra. So you can see in this upper slide, this is the Integra or the skin substitute. The shininess is due to a silicone layer that's on top of the dermal matrix of the Integra, which is made of shark cartilage and cow collagen. This is how the Integra should look. It's a good salmon pink color. And then we proceeded with the split thickness skin grafting. Unfortunately, we had an unexpected turn of events. Over half the skin graft was lost after the attempt at skin grafting, the second stage operation. And it turned out that the risk of infection indeed popped up. The skin graft loss was felt due to an infection caused by methicillin-sensitive Staph aureus. We obtained a dermatology consult to help make sure there was any other factors explaining the graft loss, and it was felt in the end that it was indeed due to bacteria. So after starting antibiotic therapy and changing some of the topical wound therapy, we started working on setting up the patient for eventual second stage attempt at skin grafting. In the meantime, it was clear that over this time period, our therapy colleagues realized that the Achilles tendon shortening issue was actually a much more significant factor than originally realized. So in the end, we ended up consulting another surgical team, the orthopedic surgery team, in this case from our colleagues at Hospital for Special Surgery across the street from us at Weill Cornell. And our therapy team can, I think, talk a little bit more in terms of the findings and the plan that y'all came up with, our HSS colleagues. Oh, okay. Yeah, I guess I'll jump ahead a little bit here, and I'll go back.
All right. Sorry, during this last admission, we had PT and OT involved because it was clear the child was not meeting his developmental milestone. It was important to have both discipline involved in his care. From the initial eval, he lacked 20 degrees in dorsiflexion and the left foot. On a discharge, it was improved through the serial casting to minus 10 degrees. The range of motion, the right lower extremity was minus 15, and we were able to gain another 10 degrees through the serial casting to minus 5. Functional mobility on the initial eval, he required, mod assist for the ambulation and because of the limitations of the ankle, and on discharge it was minimal assistance. On the developmental milestones, he was not he was not meeting his developmental milestones. It was clear, like I said earlier, impairments, unable to skip, hop, walk independently, unable to fully put feet on ankles flat on the ground, unable to sustain attention more than 2 to 3 minutes, and fine motor skills were more or less age appropriate. To improve his, standing balance, we utilized, like I said, serial casting. On top of that, in between the casts, we used standing frame to improve his ability to sustain prolonged weight bearing through bilateral lower extremities. We incorporated that with splay, so he was able to sustain that. I would say we achieved more or less success in the standing frame. You want to talk about the last one?
So ultimately, again, after his prolonged stay between the two-step surgery, we again recommended acute rehab for this individual, just to maximize what we had gained and try to continue him along his care.
Okay, very good. Yeah. Okay.
So burn outreach. So a little bit about what I do very quickly. So I like to joke around sometimes and I say, well, I wear like the PR hat for the burn center. Sometimes it's sales and sometimes it's a little bit of public health. So I'm essentially a community liaison. I partner with organizations in the community to talk all things burn. So I'm connecting with, let's say, visiting nurse service, senior centers, schools. I've had the opportunity to connect with local government to see how the burn team and the burn service line can advocate for any rules to be changed or any policies to be changed. So it's a real opportunity to identify what is happening in the community and what we can do as an organization and a burn center to help protect our patients. And when I'm out in the community, the things that I'm discussing and educating on are burn prevention and first aids. And those are just a list of areas, as I mentioned, where I'm doing some of these talks at. Essentially, you want to bridge that gap between what's happening in the community and the burn center. So a program that I think is really worth mentioning here, and it wasn't done with this specific case, is school reentry. And it's such a powerful program that is part of our mantra because it helps children transition from the hospital environment to school environment and to hopefully make their new normal kind of an easier transition. So again, bridging that gap between the hospital and the school environment. And the goal really is to increase knowledge and to have acceptance of the burn survivor. So this is an opportunity for the burn center to connect with the school and its leaders, first of all. So the principal, assistant principal, perhaps it's a guidance counselor and teachers, and provide age-appropriate education. So you'll hear us talking a lot about collaboration, and truthfully, it's key, and that's why it's so important that all of us work together. Because I work with social work to develop a program and to understand what's going on with the patient. What did the hospital course look like for this child? And then collaborating with Child Life, which is huge, because they help tailor the education to make sure that it's age appropriate. And we talk about clinical things like burn injuries, and that's the part that I would cover as the outreach nurses, looking at how these happen, what is the etiology of these injuries, and clinically what goes on with the patient, and if anybody did get burned. And then it's also an opportunity to discuss how to approach the survivor. Right? That's such an important piece of the puzzle here, because for children, they may have a lot of questions. It may be really difficult maybe for them to look at some dressing changes. Perhaps there's a pressure garment that's on the patient. So it's a chance to talk about what's appropriate, what's not appropriate. How can we make this child, their classmate, their peer, feel accepted and supportive? And the big thing really is, and what truthfully I feel the world needs a lot more of, is enhancing the understanding of what empathy is. Because Children, when they understand and they can empathize, it's amazing to see how they come out of something like a school reentry program. It's amazing to see how they want to support their peer and their classmate and how they want to be there for them. And so it's just an incredible program, and the parents are involved a lot of times. And we had a case that was not that long ago, which was, I think, last year or 2 years ago, where the patient was very involved and said, okay, these are the things that I would like discussed. This is what I would want in the presentation. This is the teacher that I want you to talk to that should be your direct resource. And this is a great way really to just integrate them back into the community, but also to show that it's important to be your own advocate even at a young age. So by enhancing empathy and all of this understanding, we're able to assist in not only emotional process, but the healing process as well.
Hi, I'm Dr. Corinne Cataruzzoli, and I'm the clinical psychologist that has had the privilege of working with the burn team for the last 6 or 7 years or so. As you've heard today from everybody on this panel, we're really working with a family, and when we're considering psychological or psychiatric sequelae of burn injuries, this is certainly true as well. So when we get involved, right at the time of admission oftentimes, or if it's a prolonged hospitalization, which is often the case for these injuries, we can be sort of a consistent psychological assessment throughout the stay. And our first goal is really stabilization. So this is a common misconception of when kids come into the hospital for a really traumatic injury, that we should immediately have them start emotionally processing it and prompting them to tell us their story and tell us all the details they remember. This, historically speaking, was the psychological approach that was used. It was called psychological debriefing. But we now have good data and research to show that it's not only not that helpful, it can actually be harmful. So in the acute aftermath of an injury, our first goal is really just to stabilize the family, stabilize the child, reassure them that they're safe, reassure them that the scary event is over and that they're safe in the hospital and that the doctors are going to take care of them here. If a child or an adolescent wants to tell the story and wants to talk about it, we can certainly listen and invite them to do that, but we shouldn't be actively prompting them. And so if there's one take home from what I talk about today, I think that's a helpful one to remember, because it can sometimes, it's a little counterintuitive. You might think it would be sort of therapeutic to say, tell me all about what happened. So that's an important piece here. The other piece with kids is to be honest. Use simple, age-appropriate language that they can understand. It can be tempting to sugarcoat things that are difficult news to deliver, about needing to go to the OR, about the length of their expected stay, about long-term consequences. But it's best in terms of establishing trust between the child and the medical team to coach the family about being honest and being direct. And oftentimes our role as psychiatry is to help the family give examples of what a 2-year-old can understand versus a 6-year-old versus a 13-year-old, or even have those conversations together. You've also heard a lot from our panel about blame, parents blaming each other, and this is, shame and blame on top of a traumatic event are not adaptive for coping. So one of our goals is really to reduce blame within the family, reduce self-blame the patient may have, that the parents might be experiencing, and to encourage the parents to present a united front to the child. So if they are blaming each other, we encourage them to sort of process that outside of what the child may witness. We also do a lot of education with parents on what's normative in the context of an acute stressor. So we often see behavioral regression, emotional regression, more tearfulness, more clinging, more crying, sleep regression, feeding regression, toileting regression, all of that is completely normative in the context of this child going through a traumatic injury. And it's important for parents to know that this is transient, to reassure them that this will normalize once they're physically feeling better, once they're back in their comfortable home environment. The hospital is a tough place to be for anyone, particularly for little kids. Another aspect of the psychological coping part of this is the connection between pain, which is a huge part of a burn injury treatment, of pain control, and stress. So oftentimes kids develop anticipatory anxiety about wound care, about PT, OT, because they know it's going to hurt. They're smart, they've learned after a time or two. We oftentimes even see these exaggerated anxiety responses just by walking in the door. When I walked in the door of a child the other day, and she said, no. And the first thing I said was, no touching, I won't touch you. So they learn really quickly. So helping to address that anticipatory anxiety, helping the team to separate out what is true pain, because there's a lot of it, and what is being exacerbated by anxiety. For our older kids, our teenagers, we talk to them about the connection between pain and stress, and how when our body is stressed out or anxious, we experience more pain because of the physiological stress response that you can see up here in this diagram. And then to help with that, we can teach relaxation strategies, things like diaphragmatic breathing, progressive muscle relaxation, guided imagery, and then also teach about cognitive ways to manage stress and anxiety. So I like a quick skill called the 3 C's that I teach teenagers, which stands for catch the thought, check the thought, change the thought. Catch, check, change. We can all use this too. So it's really about catching those worry thoughts that are extreme, looking at them objectively, challenging them, and then changing them to be more realistic, more helpful, more rational, more adaptive. These are all kind of CBT, or cognitive behavioral therapy strategies. So in general, thinking about, we want to address the whole patient from their physical health to their mental health. And in what I would leave you with is the recognition that they are not two separate siloed entities, but they very much interact and are all part of one whole child.
Okay, so just for the sake of time, let's just do this together as a group. So let's look at the first question here. What are the priorities during this phase of the patient's care going forward? Anybody?
I think using creative arts, like music and art, to work on the relaxation strategies, which could simultaneously also work on the attention span of the child, like working on different strategies, and this would push him one step forward to getting back to school.
Mm-hmm. That's great. Anyone else?
Getting the patient back towards their developmental milestones was the word we were using. Just because they're definitely behind and they can't ambulate independently, and they're going into school age, and that's going to be a big, not only physical barrier but a social barrier, and something to consider.
Yeah, definitely really important. Anyone else? Okay, so we'll go. Oh yeah, go ahead.
Increasing social supports for the family, especially the father, if he's having a lot to take care of, working a full-time job, and the main hospital of care is quite far from where they live. There are sort of different interventions we could do to help with all of them.
if you think about it, so this child is now 6. I know when they told me about the case, I was struck. This little boy, Dr. Cheng, you said he's had like 6 procedures since he was born. So what's the impact of that on the, on the caretakers and on the child himself, when you think about it? So, any other thoughts?
So moving on to the second question, what do you think might be potential challenges in managing his medical and emotional needs during this phase of his care and post-discharge?
I think with so much of a focus on his physical rehab, which is really important, it can be easy to also lose the fact that he's still like a 6-year-old child and deserves to engage in occupations that are important to him. So being able to separate out the need to meet developmental milestones, but also asking him, what do you enjoy doing, and how can we make sure that you can keep doing that?
Can he, right?
We've seen like recurrent instances of non-compliance or not following up. And I think this is an aspect where social work is going to be very important because the child is not making decisions for their care. And so I think we really need to work closely with the father to figure out how we can mitigate like not following up and making sure this doesn't happen again, because it's happened at least twice in this instance.
And that's an aspect that's not just related to social work, really all the team members, because this child needs follow-up points, with us in surgically, medically, as well as with therapy. So it ends up being a team responsibility to ensure that follow-up aspect.
It takes a village. It's true. Okay.
I would say for 7 months old, acute rehab is not necessarily first choice unless we see some warning signs or red flags, so to say. He was reaching all the milestones. Parents, even though they were not married, but they were together, there were no arguments, they were a tight group. And they were there every single day following all the directions. There were no trigger warning that they would pretty much not follow with the recommendations from the rehab team and from the medical team. We expected this child to attend therapy and progress well. We did not expect this outcome, but normally if child meeting or adult, if everybody meeting their functional goals, they walking, they're participating and everything, then why send to acute rehab? It's not necessarily also you have to look at the insurance aspect of the factors, and insurance will not pay for the inpatient stay if they see the child or adults meeting all the functional goals.
Okay, that was a good question. So let's move on to the third one. What are some considerations for follow-up? Who on the team continues to be involved in the care?
When the patient was unable to follow up, how does that typically get caught, or who notices that? Like, so in those 3 years when the patient wasn't being seen, how does that logistically work? Because I know you all are very busy and overwhelmed. So who would notice, and then how do you enable the patient to follow up? Because is that one of the reasons that the subsequent surgeries in 2021 needed to be performed?
Yeah, so I would say it's truly a team effort. I think in the situations where this has happened before, it could be therapy notifying me, hey, they've missed 3 or 4 appointments, or Dr. Chang and the medical team, hey, they've missed this appointment, they didn't pick up their garments, they haven't done X, Y, and Z. And kind of we get involved, social work, and I would say we try very hard not to get ACS involved. We try to engage the family, try to find out what's going on, what are the barriers, can we set up transportation. Often I will empower patients and families to set up their own transportation, but cases like this, I might just kind of take over and help them through that. And I think for this scenario, ultimately there was a lot of family change, and as we see, the custody changed, and I think phone numbers were changed, and so it was really hard to get in touch with this family, but I know that social work was heavily involved in trying to outreach and kind of help mediate things. And ACS was called, and I know that's something that is kind of scary, and all of us here are mandated reporters and how that works, but I think it is sometimes an intervention we have to use. And I always say, just to throw it out there, like telling a family I'm calling ACS, and so it's not as much of a, hey, this is a punishment, but we have to work together and kind of say this is what we have to do. So it's really a team effort, to answer the question shortly, but often I will get involved, or social work will get involved in trying to figure out what's going on.
There are some, I think, unique challenges practicing here in New York City in the year 2023. Number one, our population in New York City is incredibly diverse, incredible linguistic diversity. So oftentimes, getting the logistics of getting the interpreter on the phone or the video call, and then proceeding to communicate with the patient makes communication even more complicated, number one. Number two, the multiple ways that people communicate at stage, using WhatsApp or the various text messages. Our healthcare institutes do not routinely use those ways that our patients are using. So sometimes I have to go to extremes and actually use my personal WhatsApp account to reach out to patients, do it. But that's an extra step that isn't kind of baked into our systems as is. Number three, the hours that our parents work, especially I think this gentleman works during daylight hours, so oftentimes, and he can't answer his phone while at work. So the only time he can pick up phone calls is at nighttime, and during business hours, that's the only time our staff is in the office. So there are a lot of structural challenges we sometimes face when trying to communicate with patients like this.
Yeah, one other comment I'll just make real quick is we named this talk Burning Heart for a reason. We are all extremely busy during the day, but we always say once you're a Bernie, you're always a Bernie. We heavily care about this patient population. And a lot of times, if we have something called Bird Clinic, so a week after a patient gets discharged, it's not only the doctors are there, but we have an outpatient social worker. We have therapy also coming in. Even though we're recommending outpatient therapy, we're still going in and quickly examining the patient during their burn clinic. So if we see something that's not being addressed, we'll actually reach directly out to that outpatient therapist and say, hey, we're seeing limited range of motion in the ankle, we would suggest making an orthotic, or we'll even take the patients up ourselves and make what we request to keep them on their timeline of what we want to see them recover. And also, like I said, it is a specialty. Sometimes patients can't always come into New York Presbyterian to get outpatient treatment, so it's important that we still provide the best care with them within our busy schedule and restrictions.
And just to add to that, during the clinic hours, if we know there's a child that's supposed to come to clinic and they don't show up, we speak with the social worker who is also present in clinic to make sure they do reach out to the family and tell them that they actually have to make it to the next visit and ask what are the barriers, if there's transportation needs to be set up, and so forth.
Yeah, and I wanted to share conversely, sometimes you have patients that the families are very, very involved, and the patients, especially a pediatric, but even an adult, if it's a large burn and they come to us for a long period of time, it's actually really important for us as clinicians to help them get that independence to move forward, to go back into their communities, to show their skin and their burns and their deformities a little bit, because sometimes they get really attached to our team. And we're almost like family to them, and we feel like that we're family to them too. But it's really important for us to let them grow and move on. So in this case, it was the opposite case where we really needed to reel the patient back in so we can ensure a successful outcome. But sometimes we do have these patients that they're so afraid to move forward, and they almost feel comfortable in the hospital because there's a lot of recurring admissions, and we do see them for a long time. So their psychosocial component, their ability to move forward as both the patient and the families, it's really important, and it takes all of us to really, from each discipline's perspective, to get them moving forward into the next phase of their lives.
So, so as you can see, there are so many different elements, and I just want to extend my thank you and appreciation for sharing your expertise, your time, and I hope all of you have the experience, you know, of working on teams like this and seeing the camaraderie, the respect that they have, and the care that they give for their patients. So thank you, everybody, for coming. And there will be, as I said, like the evaluation, I'm sure if you guys are open, if people have other questions they'd like to ask, feel free to come on down and we'll get ready. So enjoy the rest of your day.
That was amazing.
It was great.
All the preparation helped us.
No.
Paid off.
You guys are...
So it was a little nerve-wracking.